Hello, folks. This is David Hopkinson from ENAC. A couple of housekeeping things. We'll be starting here in about a minute, roughly, and we want to welcome you to the Interoperability and Trust Dynamic Client Registration, Who Can You Trust webinar. And in a moment here, we're going to wait about a minute to let more people get online, let them catch up to the 3 o'clock time frame. And then I will introduce the Executive Director and CEO of ENAC, Lee Barrett. So give us about a minute and we'll get going shortly. Thank you. All right, just a couple of housekeeping things. When they ask, I will be running the slides, and when they ask, it takes a second or two for the slides to populate out to you folks, so be patient with the slides and me. And would like to now introduce Lee Barrett, Executive Director and CEO of ENAC. Thank you.
Thank you, David, and welcome everyone to our webinar. I think you're going to find the information that we're going to go over with you very interesting and very timely as it relates to the not only the information blocking rule, but also the interoperability rules that were released. And we'll be talking more about all of that. I wanted to let you know that the presentation is going to be made available to you. Tom Myers has a copy of that presentation, so I'm sure that Tom will be making it available to you, and or if you don't get it, you can certainly ask Tom and he'll be getting it out to you. So it will be available to you, so you don't have to spend a lot of time taking notes. The other is that we've got, as we're kind of going to be going through this whole aspect on interoperability and trust. And, while the new office, of ONC has come out with, the blocking rules as well as the interoperability rules, they're stopping short of really requiring registration without a mandated standard. ONC is encouraging health IT developers to coalesce around the development and implementation of a common standard for application registration. The coalescing, in the industry is certainly starting to take place. So what we're trying to do here is you're going to hear from our panel of experts on the webinar, including to really discuss the whole unified data access profiles, or UDAP workflows, how to promote the registration and ongoing authentication of trusted endpoints via the use of FHIR, and then the solution really to managing permissions and security at scale is really, we're trying to make that occur across millions of patients, payers, and providers. And we're going to try to explain that in very plain language to you because it's a very complex set of variables that really are comprising this. But I think what you're going to hear from the panel is a way in which we can look to kind of break that down and make it understandable, and for you to understand how you want to participate and play a role as well. So with that as kind of context for what we're going to discuss during the webinar, this is our agenda. I'm going to be going through kind of setting the landscape. Then you're going to hear from Ryan Howells on the whole Karen, the code, why establish trust, digital identity. Then Dr. Louis Moss will be talking about really defining this UDAP and what the problem it's looking to solve, what it can do, what the projects it's being used for today. Louis is going to kind of put it into perspective. And then you're going to hear from Aaron Seib on the patient caregiver perspective and how we're trying to make it easier for patients to establish this whole trust framework outside of HIPAA. And the whole issue around, hey, who is in fact, what organizations or can look to certify this and what's going on from that perspective. So we're going to really try to put all of this in perspective for you. So with that as kind of the agenda that we're going to walk through, let me introduce our panel. So our first panelist, after I kind of set the landscape here for you, is Ryan Howells, who is a principal at Levitt Partners. Ryan has worked with the White House, the VA, CMS, ONC, OCR on a number of healthcare issues and is a frequent speaker at major industry events. He currently helps lead the Karen Alliance, which is a multi-sector public-private alliance focused on providing consumers digital access to their health information. Ryan is also a member of CMS's Medicaid Information Technology Architecture, or META, governance board and a board observer for a major technology company. He received his master's in health administration from USC, where he was also a Dean's Merit Scholar and bachelor's degree in English from BYU. Louis Moss is the Chief Technical Officer at EMR Direct. He holds a bachelor's and master's degrees in electrical engineering and computer science from MIT. He has an MD degree from Harvard Medical and a doctorate in medical engineering from Harvard MIT Division of Health Sciences and Technology. He's also a board certified radiologist. And after completing his postgraduate training at Harvard Medical School and the University of California at San Francisco and San Diego, he worked for 10 years as a clinical radiologist in San Diego before changing gears to health information exchange. He's actively involved in standards development, including work with HL7, the Direct Project, the Open ID Foundation, Direct Trust, and UDAP, with a focus on security aspects of health information transactions. He is also a co-lead for the ONC Fire at Scale Task Force Security Tiger Team, and he's charged with developing a scalable security solution to support the Da Vinci Project and the fire information exchange workflows for health insurance providers. Aaron Seib is the Chief Strategy Officer for Onyx, and he is nationally recognized for his work related to enabling the sharing of health information, including his work with ONC in a variety of areas, including he also participates on the Fire at Scale Task Force Tiger Team for Security. He's been involved with the National eHealth Collaborative and in the Western State Consortium, while as the state HIE policy and subject matter expert in California. He was also the CEO of the National Associated for Trusted Exchange, and he's been very involved with his work with CMS regarding Blue Button 2.0 API with Mark Scrimshire. And as Chief Technology Officer of Onyx at this point, with Onyx is a product and services company whose flagship product is a product called Sapphire, which is a leading interoperability healthcare platform. So that's our panel for today. And again, all of them are bringing very interesting perspectives and expertise to this entire topic, which I think you're going to find very interesting. What I also wanted to tell you is on your right-hand side of your panel, if you have any questions as we're going through the presentations, please type in your questions. We'll try to get to as many of them as we possibly can. What we're going to do is have each of the panelists go through their presentations, and then we'll open it up for Q&A. So hopefully we'll have plenty of time to address your questions, because this is really, this panel is, and this entire webinar is really for you. Okay, next slide, David. So what I'm going to try to do as far as kind of setting the landscape here is to talk to you first about this first slide here gives you kind of the framework of the 2020 to 2025 Federal Health IT Strategic Plan, which the U.S. Department of Health and Human Services came out with back in January. So what this talks about here when you start to look at it is kind of the various aspects at a key level of what they want to include in this 20 to 25 plan, which includes everything from promoting health and wellness to enhancing delivery and experience of care, building and securing data-driven ecosystem to accelerate research and innovation. And then you've got goal 4, which really focuses on connecting healthcare through an interoperable health IT infrastructure. Everything from here, basically development and use of health IT capabilities, the establishment of really a transparent set of expectations for data sharing, the enhancement of technology and communication infrastructure, and then the whole aspect, which I consider to be foundational around privacy and security of this ecosystem that we're looking to build. Next slide, David. So as you start to look at this, and then this slide is also from the report, the 2025, but as you start to look at kind of the various factors in healthcare industry, really we're demonstrating really a strong need for solutions to be provided, such as really the trusted dynamic registration, authentication, and authorization implementation. And while we're seeing many healthcare networks and exchanges are in place today, interoperability continues to remain really a key challenge, particularly in support of the automation of identity authentication. As driven by really the 21st Century Cures Act, ONC published a draft of their Trusted Exchange Framework with Common Agreement, or TEFCA, which is really the initial set of regulations facilitating the industry move to interoperability. And really, as of the draft that came out in 2020, back in April, the industry has really been awaiting really final information blocking and interoperability rules from the Office of the National Coordinator, which were published back in March 9th and published in the Federal Register as of May 1, 2020. And so, you know, when you start to look at all this, it really starts to further clarify the processes for patient access and permitted options for vetting the registration process. It's really expected that the needed registration process can't become the responsibility of each electronic health record, as it is the case today, so thereby kind of driving the need for a solution which can be broadly accepted. So additionally, when, you know, as I mentioned, HHS developed and released its draft of this 2025 Health IT Strategic Plan for comment, it really outlines really the federal health information technology goals and objectives, and really to assure that individuals have access to electronic health information in an interoperable manner. The plan also accentuates the recent changes in technology for our world, really such as the increased use of smartphone applications by all, including patients and individuals, and related use of application program interfaces, or the APIs, which are further strengthening the need for protocols to assist in identification of users. And as we look to kind of delve into the technical aspects of how the desired state of real-time interoperability is going to occur, attention needs to really be drawn to the multitude of volunteer work efforts that are going on and occurring throughout the industry right now, with both the private and public sector efforts really that were launched by ONC. In 2017, and you heard me talk about both Aaron and Louis, as well as myself, involved with really the Fire at Scale, or FAST task force. It was convened in 2017. They started this, and it really was focused on bringing together motivated healthcare industry stakeholders and information technology experts to identify fast, really scalability challenges, the approaches, and the barriers to adoption. The group, you know, the Tiger team, is basically focused on the infrastructure needed to support the data flow in an interoperable manner, and really, again, the efforts support really the adoption and the promulgation of FHIR across the industry. The work is really imperative as the current ONC and CMS rules, as we talked about under 21st Century Cures, supports interoperability in healthcare data, including kind of the expanded use of APIs to facilitate access to care coordination, patient health, and provider directories. You know, and in its kind of January 2024 platform or forum that they're looking for, the intent is really to release the documentation and the adoption as well this past year in 2020 around the trusted dynamic registration, authentication, and authorization protocol. So there's a lot of support for it within not only the FHIR Tiger teams and ONC, which really I think you'll find as you hear the other panelists is very an important aspect that you need to be aware of within your own organizations and how you're going to look to implement and take advantage of it. So with that, let's move to the next slide, and I'm going to turn it over to Ryan from Levitt Partners, who will take us through kind of advancing the consumer-directed exchange. Ryan.
All right, thanks, Lee. If I could just get screen sharing privileges.
Do you have them now, or are they showing up?
I have not seen them yet.
I sent it to Lee Barrett. Let me try different.
David, you're sending it. You sent it to me.
Okay.
And it needs to go to the second individual there.
Unfortunately, I did, and it didn't show up for him. Bear with me a moment. Ryan, do you see it now?
While we're getting over to Ryan, we're kind of doing Ryan's going to take you through his perspective here, which again I think is important as we're looking at kind of this whole aspect. Yeah. Do we have? Did Ryan have it yet?
Not yet, but do you?
Lee, I could quickly share a little bit to provide some, real world experience from the work that we did in CMS and why the topic of dynamic app registration and app verification, certification, independence is super important. If that help while we get Ryan all ironed out.
Okay.
Just to give folks sort of a reference point, I worked with CMS with Mark Scrimshire and a bunch of great, federal government employees to bring to market and actually release an open API based on FHIR from CMS for fee-for-service beneficiaries that involved enabling, via the technologies that Ryan will be talking about, the ability for individual beneficiaries to retrieve their pay claims information and share it with a consumer app of their choice. We actually started the journey 5 years ago with before there was really any FHIR standard specific to sharing pay claims, referred to as explanation of benefits data in some of the resources, and we actually worked closely with the FHIR Foundation, the FHIR members, the FHIR community to establish this use case of defining the standard resources that we'll be sharing between data holders. And at that stage, it was just CMS and Medicare beneficiaries using to-be identified consumer apps. When we started out, we didn't expect things to grow as fast and as large as they did. So 5 years later, I'll share with everyone, we currently have over 1,000 consumer apps registered for access to our sandbox, and 60 of those apps registered to enable production access to those APIs. And I can share with you after Ryan and Dr. Moss's presentations are done, a little bit about those metrics and what it took to get 60 apps into production and how much effort that it involves and why we really have to find a scalable solution. But back to Ryan.
That'll be great. Thank you, Aaron. Ryan, do you have control yet, or is this?
Yep. Can you see my slide?
Yep.
Okay, great. Yeah, so let me run through these. I have more slides than we have time, so I'm going to go through this very quickly, but you'll see the slides afterwards. We lead a group called the Caron Alliance, which is focused on getting consumers digital access to their data. Our focus is exclusively on what we would call the FTC space. So we have HIPAA-related data exchange today. The ability for consumers to aggregate their data is actually via the use of these application programming interfaces that happen in the internet economy. And our focus is on ensuring that consumers can aggregate their data on one or many apps across not only providers, but also now health plans, which is the primary foundation for the CMS rule. This has the opportunity to literally solve thousands of use cases in healthcare. When we move from organizational-centric data capture and data ingestion to person-centric data ingestion, it actually has the chance to really look at longitudinal health information and being able to have an impact on people's lives. So that is our vision. We want to really find a way for individual authorized caregivers and consumers to easily get, use, and share their digital health information when, where, and how they want to achieve their goals. We have about 70 organizations roughly participating in Caron, including Google, Apple, Microsoft, 7 of the 10 largest health plans, all the EHR vendors either directly or through their association, pharma companies, patient advocates, caregiver advocates, and many, many others that are focusing exclusively on this vision. How do we empower patients to be able to aggregate more of their health information when, where, and how they want to achieve their goals? One of the first things we tried to tackle is this idea of trust. And as I mentioned, as we saw on that slide earlier, this idea of trust is interesting because we trust HIPAA today. Our data does not leave HIPAA. But once, at least in a digital format, once the data actually leaves HIPAA, it is no longer in a trusted environment. In other words, it moves regulatory environments. It moves to the Federal Trade Commission, which is oversees consumer data in what's called the FTC Act, Section 5A, which says do no harm to the consumer. And as the Federal Trade Commission, we are going to go through and enforce the individual privacy terms and conditions for the individual app. And so if it's a nefarious app, we just want to make sure that it's following and is consistent with what it says is they are doing nefariously to the consumer. Well, in healthcare, that just does not work. We are exchanging personally identifiable health information, not only within HIPAA, but now outside of HIPAA. And we need to make sure that privacy and security is of the utmost importance, and that, in fact, we can actually raise the bar in terms of the privacy and security opportunities that may exist in order for individuals to then be able to aggregate their data. So we did that through what's called the Caron Code of Conduct. It is foundational. We had 60 organizations participating over the course of 18 months and published it last year as being a set of key principles for apps to follow so that they could be able to then enforce them in a meaningful way with individual third-party apps. The code of conduct is meant to be used when an app actually registers with a data holder like a health plan to be able to access that information. So from a technical perspective, when they register to get the OAuth token, they will be able to also attest to the fact that they follow the Caron code, as well as many, many other things that may be asked for as part of that registration process. And the reason that's so important is if as an industry we can agree to a common code that can exist everywhere, the FTC can actually enforce that code. And frankly, many private sector entities can look to do that as well. The good news about these apps that are in the ecosystem, and there's not hundreds of thousands, there's probably less than 60 or so that actually have access to the FHIR APIs in a meaningful way and that being used today in production. And all of them are using data privacy and security as a competitive advantage. And so I think you can take comfort in the fact that that's the case, but we still need to plan for nefarious actors. And that's one of the reasons we wanted to have that code in place. We have done other stages of trust as well. We want a questionnaire, meaning an ability for consumers wherever they go to access their apps, that they're going to do so in a kind of a common user interface. Think of it like a nutrition label for privacy. And then the third idea is validation. We need third-party certifiers like an ENAC, for example, and Lee's organization to come behind us and say, put their stamp of approval and say, not only have they attested to it, but they are actually doing what they said that they would do in terms of these best practices. And those stamps of approval, like ENAC and others, we think are very, very important. And we're going to work with Lee and his team over the course of the next few months to be able to have that validation. One of the other ways that we're establishing trust is this application, or this website called myhealthapplication.com. People have asked us, where do we go to find these apps who can actually connect to clinical and claims data? Well, this is one place you can go. There are others as well that you can be able to find out who they're connected to. Have they connected to CMS Blue Button? Have they connected to Care Equality or Commonwealth, one of the trusted health information networks out there, or the Veterans Health Administration, or Apple Health, for example? You can be able to find that information here. We hope that it's going to be a really robust place where people can go long term. The other way of establishing trust is identity. And that's going to be our sole focus today, is around identity and what that means in terms of an open framework for making this happen at scale. One of the things that's important is that in healthcare, we have historically looked at identity as organizational centric identity. I go to every health plan, every provider, I present myself, I get some kind of identity proofed in some way, and as a result of that, I get a username and password to a portal. That's kind of how it crosses over. Well, we're going to move that online, and we're going to move that to more of a person-centric approach, because when I go to the DMV, I present 3 forms of identity. They present me a physical credential, which is my driver's license. I can then use that as a trusted identity credential across multiple different organizations. Well, in the digital world, we can do something similar. We can go out and get 3, 4, 5 different authentication mechanisms to ensure that you are who you say you are from trusted sources. We can then be able to give you a digital credential that's person-centric, like Real ID and like the mobile driver's license movement that's actually up and running now in about 6 different states, and soon to be dozens more in the years ahead, where literally you will be able to have your driver's license on your mobile device. And think about a world in which you will be able to take that digital driver's license, and again, it doesn't necessarily have to be a government-issued ID. We can do this for undocumented individuals and others as well to be able to make this happen. But think about it in terms of getting a digital credential, and that digital credential could be used across multiple systems. It's been identity proofed, and literally as almost like a single sign-on effort, you can actually use that across multiple different systems, and it's all going to be based on your individual consent and your preferences. We had a summit with CMS and ONC back in June. We don't have time to talk about it, but it was fun. We also are working on an approach to digital identity federation, meaning we need to have trust in the ecosystem. How does Cigna actually trust Humana's credential? I'm making all this up, of course. But how do actually relying parties trust other credentialing service providers? That's a question in the ecosystem. We are developing a set of open contractual terms and conditions anyone can use to be able to make this happen at scale. We're working very closely with Care Equality and the recognizing coordinating entity to find ways to be able to include that as part of broader contractual terms. And then there'll be third-party certifiers that be able to come behind us to ensure that they're doing what they said that they would do. And let's talk about as well what we're doing with the patient access final rule. There's a lot in that final rule. Our primary focus within Karen is this patient access API, which is the ability for an individual member of a health plan to aggregate both their claims and their clinical data from their health plan of choice. And that is effective as of January 1st. The CMS has actually implemented what's called enforcement discretion, which means we're going to look the other way and not enforce these rules until July 1st of 2021. And so sometime between January and July 1st, all of the health plans that are government sponsored will be implementing these API infrastructure. What are we doing as far as the APIs themselves? We won't get into a lot of detail here, but CMS Patient Access API involves administrative and financial data, which is Karen Blue Button, and it also involves clinical payer data as well, a 5-year look back information, and that is as through Da Vinci or through USCDI. So both of those pieces of information are going to be aggregated by the individual member. A lot of great links for you to take offline. We don't have time to discuss. I'm not going to go into a lot of detail here other than to just say we are also working on an API for real-time pharmacy benefit check, which is actually required by all Part D health plans by January of 2022. It's actually been proposed, I should say, as Part D technical changes that a real-time pharmacy benefit tool should be required by all Part D plans by January of 2022 for consumers, actually, to make that happen. And so we are looking forward to being able to implement an ability for a consumer to get access to their formulary and benefit information, their out-of-pocket cost information, their therapeutic alternatives, and their cash price. All that information can be made available in a FHIR API and to the consumer an app of their choice. And this is very similar to what the provider is seeing today related to an NCPDP standard that uses EDI to actually be able to access similar information. So think about at the time that the patient is actually getting the physical prescription from the provider, they will be able to, on their own app of their choice, look at the same information, very similar information that the provider looks at, and be able to make a real-time decision. Do I want the cheapest drug? How do I counsel with my doctor on that? Do I want the most efficacious? Which ones am I allergic to? Which ones haven't worked for me in the past? All of these questions can be asked at the point of prescribing. And both the patient and the doctor can actually go through that process together and really be involved in shared decision making. That's the future of drug prescriptions. So more information on that. And then this is my last slide, and I'm going to turn it over to Louis. But why are we talking about this thing called UDAP, which I'm sure many people on the phone haven't heard about? But we're hopeful from a technical perspective that the technical teams will be able to look to implement this. And why do we need it is really the question I want to answer, and then what it is, and Louis is going to answer for us. The first problem we're trying to solve is that we don't want health plans to be in the application store business, meaning EHR vendors do have individual app stores. There are going to be tens of them across the industry. There's 300 plus EHRs. There may be even more than that. We don't want hundreds of other app stores in the health plan sector either. Most of our health plan members in Karen have told us that's obviously not the business we're in. UDAP provides a way to streamline that, to be able to find ways where we can provide incentives for applications to follow industry best practices and streamlining the registration and onboarding process. Secondarily, interoperability data sharing is now required. It's not optional. So how do we scale that? There will come a day when there will be hundreds of applications that will be knocking on health plans' doors around the country. And the intake for those apps and being able to register those apps and providing them a token and finding ways to establish trust needs to scale. And we're thinking about that now rather than thinking about it years from now when we do have hundreds of apps and you've hired hundreds of people to manage that. That's not the intent of this. Our intent is to create a trusted ecosystem, and by doing so, we can have the technology and the policy guardrails in place to ensure that this data is protected and secure no matter where it sits, whether it's inside HIPAA or outside HIPAA. And frankly, some of the things that we're including UDAP is raising the bar in terms of those security. And then finally, we do need a policy and digital identity federation model, similar to what I talked about before. We need a way to ensure that credentialing service providers can trust relying parties can trust other credentialing service providers in the ecosystem. There needs to be a way to make that trust happen. Louis is going to talk about the technical way that we are proposing to make that happen, and I spoke earlier about the policies and the contracts that need to be in place to make that happen. And so as we move to more person-centric identity, both are important to be able to scale that around the country. So with that, Louis, I will turn it back over to you.
Thanks, Ryan. And the ENAC administrative user is the who to turn it back over to. Thank you. All right. I'm going to wait for David to get my first slide up. In the meantime, I'll tell you a little bit about myself and EMR Direct. I want to thank Lee for the kind introduction. EMR Direct, we're a health IT developer, so we offer FHIR and OAuth services that can be integrated into other data platforms, including EHRs for healthcare providers, payer systems, care coordination systems, and other platforms. So the question about how to make app registration and access easier is clearly an area of great interest to us. I'll start a little bit with how it is today, as Ryan alluded to here. Typically, this is a very manual process now, where every client app is repeating some form of manual registration process with every data holder, every information source here, the FHIR server, OAuth server player. This is not the way the industry wants to continue to go. Standing up hundreds of app stores is not a good way to do this. There's a lot of other benefits that can come from streamlining this, and I'll go over some of those as we go through. Ryan mentioned there are about 60 apps out there now. I think we're just getting started there. Aaron is going to go through some math to just show you the burden of human cost in just with 60 apps in the current payer environment. We're just going to see more and more of these apps as they proliferate, as the patient API, the patient access API, and the payer-to-payer data exchange requirements start to go into force. So what we need to get ahead of the curve here and to make this so it doesn't break everything when we hit those points is a way to automate the registration process so that this ecosystem can scale naturally and easily. This really comes down to reusable credentials. We'll talk a little bit about that. And then using those appropriate those credentials to ensure there's appropriate authorization to data and access to data. That means that we have to have a reliable identity. We have to know who the other actors are in a way that is trustworthy. And Ryan was hinting at that as well. In the payer-to-payer exchange, especially when where you won't have your own credentials for these consumers, you really are going to need to know, this really is payer to asking for this data and not an imposter, right? We'll get to that as well. You can go to the next slide, please, David. So I'm going to cover some of the high points of what's possible here. Looks like some of the slides getting cut off at the bottom, David. I'm not sure if it zoomed in or something. Thank you. Get it to fit on the screen. Yep, still a little too big. All right, I'm going to go through here some of the highlights of what you can accomplish with UDAP, and hopefully after this you'll understand why the UDAP profiles are core to the ONC's FHIR at Scale Task Force Security Model, and why they're part of the Karen implementation guide and the Da Vinci implementation guides that you've probably heard of or probably even worked in. If your organization is in the Da Vinci project, you've probably heard their architects talk about how the Da Vinci protocols are the cars and the ecosystem are the highways for data exchange. And in that analogy, you can think of the UDAP credentials as the equivalent of the license and registration to operate. So that you can see who the players are and understand that they're authorized to do what they're trying to do. So that's pretty important. This model is based on asymmetric cryptography, which many of you know basically forms the whole background of trust for the World Wide Web. And all e-commerce today basically rests on asymmetric cryptography to establish trust in the server actors. This public key technology, basically, in short, I'm sure most of you already know this, but there's a private key held by the actor, the person, the organization, or the server, and then there's a public key that's shared that can be used to verify information that is signed or encrypted using the other key, or vice versa. You can encrypt with a public key, and that can be then decrypted by the actor with the private key. This is well-established technology. It's been around a while. It's widely used in the web. There's a new, relatively new entrant to the internet ecosystem, which are these JSON-based entities like JSON Web Tokens or JWTs or JOTs. And these essentially provide a way that you can sign data using these keys. And upon these bricks, some very common and standard protocols that you've probably heard of have been built. OAuth 2.0 is the principal mechanism for authorization of RESTful APIs like FHIR. And OpenID Connect is built on OAuth 2.0 and is used for authentication of individuals that want to perform activities on the web. So the UDAP profiles basically build on this, since a lot of the technology platforms out there already that do FHIR and OAuth already support these background pieces, and so adding on this other stuff, it makes it much easier than ripping and replacing, as you could imagine. And then, unlike the regular OAuth and OpenID Connect, which also center around the idea of very few servers and customers that will just register over and over again because that's easy, which, as we've discussed in our ecosystem, is not easy. We want to make this reusable credential, and for that we're using digital certificates. These are the X509 certificates, very similar to what you've seen to secure websites. And UDAP ties together OAuth, OpenID Connect, and digital certificates in a way that that hasn't been done at scale before, but brings the advantages of both of those areas together. So you get all of the benefits of the X509 digital certificate world, including the ability to establish trust across a number of different issuers, so that you can do this independently as a receiving party. You can build these trust chains and determine if a certificate is good. The ability to, importantly, revoke a certificate if somebody is a bad actor or leaves a data use agreement or something of that nature. And other interesting topics like the ability to then track an operator, one of the actors on the network over time, which obviously has some benefits in things like shared cybersecurity reporting and other mandates that you may have regarding that type of thing. For those of you who are very technical, the UDAP profiles are designed to work with both the client credentials and the authorization code flow workflows in OAuth, which is important because the CMS rule has two requirements, and the payer-to-payer data exchange we expect will typically be client credentials flow, and the patient access API we expect will best be solved with the authorization code flow. So this one framework adopts or handles both of those requirements. Server validation is also important. When you're connecting to someone, you want to be sure you know who you're connecting to. Sometimes TLS certificates for websites are not enough there, especially in multi-tenant environments. So that's an important addition. Certifications and endorsements are what Ryan was also alluding to. These are extremely important and valuable additions here. Certifications and endorsements can be issued to apps by third parties. So this would be a way that you could know, for example, that ENAC has reviewed the security practices of an app operator. It can also be used for app self-assertions, such as adoption of the Caring Code of Conduct, as Ryan was describing, so that the application operator can present that information to you when they register. And it could even be verified by a third party, as Ryan was stating, that someone has not only has this organization adopted the Caring Code of Conduct, but an independent party has validated that they're actually following the Caring Code of Conduct. So this idea of verifiable credentials, you've probably heard this in other scopes, but you can attach these things to an app. The app can go earn these badges, if you will, and then present them to the registration endpoint when they're trying to connect to you to get your data. And if you're working with user-facing apps, this also gives you some information that you can present back to the user to increase their confidence in what's going on as well, as suggested in some of ONC's patient education requirements. And if it's a back-end process like a payer-to-payer exchange, the same thing is going on, except your system is making these decisions based on the identity of the other actor and potentially the combination of certifications and endorsements that they present to you in deciding what they're going to get to do. Tiered OAuth, I'm going to just touch on briefly here. This is a really powerful tool where imagine your patient portal credentials in your payer portal. This provides a way for that patient to be able to go and sign into a hospital system using your payer portal credentials, so that they don't have to go and sign up for patient portal credentials at the 7 providers and 16 hospitals they go to. They can use the payer credentials over and over again to do all of that, which obviously patients would be very happy to not have to have 17 different sign-in credentials. And so that's we'll talk a little bit more about that if there's time, but I think there probably will not be. Next slide, please. So UDAP is actually a collection of profiles that fit together nicely to create a very robust ecosystem where these registration events can happen right in the middle. As you can see, the middle gear is the trusted dynamic client registration. That enables all of these other things, some of which we've talked about, others which these are all hyperlinks, so I'll leave it to you guys to review these if you'd like on your own. On the next slide is kind of a technical wire diagram, very fast to show you how this looks on the wire. I won't spend too much time on this, but basically OAuth dynamic registration is extended to be trusted. So the application doesn't have to go to a website to register. It doesn't have to go to an app store and tie up your human resources reviewing those apps and vetting them again and again and again. Instead, there is an industry trusted framework, and the app can get its registration and vetting done once, and then have that reusable credential that it presents to your OAuth endpoints to get its local client ID, which for the non-technical folks is basically what the app needs to connect. And then that plugs right into the rest of the workflow where they can then come back later in the context of a patient or in the context of other workflows in this is required by the CMS rules to request an access token to data. You will have that registration information that you can check. You can verify that their certificate is still in good standing and that they haven't been removed from the network for bad behavior or other reasons, such as going out of business or leaving the agreement. And then you can use your own internal logic to decide whether they have access and what access they should have to what data, with those little gears representing that policy engine, after which standard FHIR transactions can take place. So this builds right on top of standard FHIR services, such as the FHIR servers that we offer, and plugs right back into that common workflow in step 5, and 6. So we can go to the next slide. This is an example of what it would look like for a consumer-facing app to show that it's a trusted app. I think we're cutting off the very top of the screen here, or a little like in between slides, David. Thanks. This is a trusted app. This is an example for a patient-facing app from a health system using US Core Data for Interoperability, which is the new ONC requirement. This would equally apply to a payer system. If this were ABC Insurance Company instead, then instead of the bullet points for observations and conditions, it might say coverage and explanations of benefit, something of that nature. The information about the app is presented at the bottom here. You can find out who the app claims to be, so the user can make sure this matches what they're expecting. And trusted information can be highlighted in our production systems We use a green lock for this, and the trusted information is presented next to that. Who's really running the app, what's really their privacy policy, things of that nature that would be important to the user, and possibly even for you to accept that registration. So this might be a place where an indication that they have adopted the Caring Code of Conduct would appear, or that they've completed, that they've been vetted as having good security practices by an auditor such as ENAC. The key item here is that, the same process also takes place in the payer-to-payer exchange. It's just in those back-end systems, there's no patient signing in, so your system can make those same decisions in the background and understand those same concepts. So to wind up, I'll go to the next slide. The UDAP framework basically follows a common three-step process. There is this reusable credential where the user, client, server, whoever the actor is pre-registered. With that, the subsequent registration and use of services can be automated. Different degrees of vetting can be attached. Self-assertions can be attached. And then based on that, when the actor wants to do something, when that client app or that user or that health system or that healthcare system comes and wants data, you, as the relying party, the server, you can dynamically register that party without having to run your own app store, without having to have a whole department to vet apps and app developers. And then you will have a good, reliable identity of that actor. You can move on to the next part. When you get their query, you'll know what they're asking, who's asking for it, and in what context, so that you can make proper decisions about access and follow all the necessary regulations that would apply, be they HIPAA regulations for payer-to-payer exchange, or FTC and or HIPAA regulations as may apply to the patient data API. But the framework basically covers that because it gives you the information you need to make the decision. So in a nutshell, that's how UDAP works. I'll go to the next slide here real quickly. There are a few other links that might be useful to those on the technical side that want to dig in deeper. The actual underlying profiles that have been profiled further in DaVinci and Karen are listed in the www.udap.org. There's a 2-hour extended webinar that gets a lot farther into technical details here through the ONC Fire Scale Task Force. This is from last December. You can also follow this link to see that if you want to get into a real deep dive into the on the wire and such. Or of course you can contact me and I can get you pointed in the right direction. So with that, I will pass the baton here to Aaron Seib, and thanks guys for listening.
That was incredibly, very, very helpful, and it actually makes it possible for me to breeze through these slides, because I think everyone who listened to, what Ryan had to share and what Louis had to share as far as the complexity of this review process. When I think about what we did when we were working with CMS, I think it's very obvious to a lot of folks that this is not something you can do in between tasks, or have your team working on this and any other deliverable. This is literally becomes a full-time job in the manual world for many, many people. That we're talking about based on the experience I had doing this with CMS over the last 2 years. So when you've got a single app and you want to have that app access your data, your data source, approving it once, or approving any use case once is really simple. Next slide, please. But what we're really talking about is establishing trust across many endpoints. If we just narrow it to the 907 plus or minus health plans that we have in the country, the scale of this problem becomes immense. And the cost and the lost productivity working on doing the same tasks over and over again between data holder to data holder to data holder, not only creates an unnecessary burden on the data holder, i.e. the payer, but also makes it very difficult for innovative apps to be sustainable. A great deal of cost goes into being evaluated by any entity that's going to review your application. So in the app developer's perspective, that the consumer wants to have that cost occur once and be used many times. Next slide, please. So I just taking a look at the math very quickly, there's a total of 907 health plans. Currently, there are 60 consumer-controlled apps that have production access to the CMS Blue Button 2.0 API. So if you go to the next slide, we end up doing some math where just thinking about the time that we're on the phone, not to include all the validation steps that happen that Louis talked about from the technical perspective, which is going to be required of every evaluator. Just on the phone, we've spent 73 person years, essentially getting onto conference calls after spending hours evaluating the materials that have been shared with us and looking into what are the things that we need to question. We need to have a follow-up meeting. Now that we've had this follow-up meeting, we get together with our peers and we make this decision about whether or not to approve the app. What additional information will we need if we don't approve the app? A great deal of really low value time. And the way to make that more valuable is to have that review process happen once and be used many times. And the review process is not necessarily specific to all types of exchange. We start with small steps, like what the Karen Alliance has done, and like what Louis was talking about around identity. And now that we have identity, and now that we've identified a use case and we've created a pattern, how do we scale that pattern out so that we can enable all kinds of use cases? So again, the next slide, please. What we're really looking for is an opportunity to do the evaluation process once and actually have somebody who is on the hook for doing this in a maintenance mode. So today we are reviewing apps and approving them, and then 2 years from now, when there may be 700 apps, we have 1,000 apps participating in our sandbox environment. Next year we'll have 700 apps to re-review. So this is obviously something that is, not only something that requires a great deal of specialization, therefore something that you might want to outsource, but also something that is not necessarily adding a great deal of value to the organization. If ENAC or any of the other certifying bodies can perform that service, and you can combine a number of those certifications to answer your policy questions before approving an app in a dynamic way, you save your organization a great deal of effort. You allow those who specialize in it to help you get the best results possible without losing the functional equivalent of a person's lifetime. Next slide, please. So I just wanted to try and reference to, as I shared, we've built a public offering, a commercial offering to enable payers to meet the CMS mandate and use that as a stepping stone to other interoperability use cases. And really it comes down to three components, three modules. The first one is to have a lingua franca, which we have, which is FHIR. The second is to have a trustworthy authentication and authorization protocol, which works at the individual per enterprise level today, Smart on FHIR. And then a process for approving drivers, to Louis, to the metaphor that Dr. Moss referred to. How do we verify the identity of the person who's making that authorization to share the data? And also importantly, how do we register the cars they're driving in and verify that those cars comply with and miles per gallon registration and so forth. All of those things that we do in many other industries, but in healthcare currently in the health information sharing space is an extremely manual enterprise specific solution. And at the end of the day, we do want 1,700 consumer apps because we want to create very specific experiences for the different people that we're serving. An application that's really useful for a family with a senior in their family with end-stage renal disease is going to be much different than one that's for my parents who just recently retired. One for somebody who's suffering from diabetes is very different than one from somebody with congestive heart failure, high comorbidity patients, even more complex. So it is beneficial to the economy and it's beneficial to the consumers to have many of these apps. But unfortunately, interoperability only moves at the speed of trust. So the next slide, please. As I shared, we're working on enabling trusted exchange, And today we have built an end-to-end solution for the CMS mandate that some payers are choosing to use. And many other people are putting this into the market as well. But again, this type of platform, this solution, this end-to-end turnkey solution for meeting these mandates and others can only move at the speed of trust. Next slide, please. And that's why we're investing so heavily in adding the component, the module that will leverage the things that both Ryan and Dr. Moss have talked about today. At the end of the day, it's the policy of the data holder that authorizes the sharing of data being accessed by a third-party application. And part of the platform that we build is intended to make that review process as painless as possible. And we believe strongly that enabling certified apps to make it easy for payers to discover those certified apps, and when those certifications meet or exceed the requirements for a particular use case, that we can dynamically register those apps with little or no human intervention. So that would be the success story for the next round of innovation in health information exchange. And with that, I know we're out of time, but I hope we can stick around for some questions. Happy to talk to anyone.
Thank you, Aaron. Thank you. And I know that I didn't see any questions that were posed, and I know that we're at top of the hour. Hopefully that all of you as participants here got a really good perspective. I mean, I believe that how kind of Ryan kind of laid out what they're doing, as well as Louis, as far as explaining the UDAP process, and Aaron kind of putting it into perspective for you, gives you a pretty good idea as far as kind of interoperability and trust and this whole dynamic client registration process. So with that, first of all, on the last slide here, you can see all of our contact information, so that if you do have any questions after this, please, you can contact either myself with the question or any of us on here with your questions. We'd be more than happy to get back to you with an answer. And with that, I want to thank all of you for participating on the webinar, and I want to thank the panel, Dr. Louis Moss of EMR Direct, Ryan Howells, Principal of Levitt Partners and the Karen Alliance, and Aaron Seib, Onyx Chief Strategy Officer. Thank you all, and David Hopkinson for running our show here, our webinar. Thanks to all of you. Please stay safe and your families, and we look forward to talking to you again soon. Take care, everybody.
Thank you, Lee and David.
Thank you all.
Thank you. Bye-bye.